of this course, but also to ask you to take the time to give us the feedback on the course. This is the first time you'll see where we have had, we designed this course to have a plenary session for mechanical circulatory support, the issues that are relevant to both heart and lung, and then have a lung stream and a heart stream for some of the specific issues. And I know there's lots of overlap, but it is unique to have more attention to lung mechanical support as the field is developing. So we hope that you'll enjoy it. And I will hand over to my co-chair, Professor Walter Klepetko from Vienna, to introduce and take over.
Thank you so much, Chef, and thanks for putting this interesting program together for all of us. It's really an exciting thing, and it, in my opinion, opens new doors, and hopefully opens also the eyes of many people how important these technologies are also for the thoracic side of our community. So having said that, I invite you to give you a presentation on the really more and more important topic of extracorporeal lung support bridging towards lung transplantation.
Great. Thank you very much, Walter. I'd like to start by disclosing that I am a founding partner of 3 companies that we've spun out of the research we've done, had significant research support from Ex Vivo and United Therapeutics, and Fresenius is also an investor in our company, and also very importantly, Fresenius has been a very important supporter of this course for the AATS, and we're very grateful for that. So extracorporeal lung support as a bridge to transplant is becoming increasingly applied. In the early 90s and 2000s, it was sort of viewed as futile therapy for very sick patients, but as you can see, in the UNOS registry, the application of ECMO as a bridge to transplant is increasing in its application. And there are series that would count really pretty much as small numbers in any disease condition you're looking at, ranging from 20 to 124 patients. This is from Walter's group in Vienna, showing that you can, successfully bridge 70, 80, 90% of patients to transplant with a reasonable expectation of long-term survival in the range of 80% at 1 year. And we set out to look at our experience of patients bridged to transplant in the Toronto program and identify factors that were linked to optimal bridging. I think in general, indications for bridging to transplant include hypercapnic or hypoxemic failure and also hemodynamic failure in the case of primary pulmonary hypertension patients. And I think it's also very important that this decision for bridging is made in advance by your multidisciplinary team so that you know what the objectives are for a specific patient that is on your list. In general, we have some criteria that we make as relative exclusions, although, as I was making the slide, I could think of ones where we've made an exception for a patient over the age of 65, for a bedridden patient, for a patient who's had a high BMI, and so on. But by and large, each of these factors here are factors that are linked with a poor outcome, a poorer outcome. I think we've learned more and more as the field has developed and as technology has developed that your bridging strategy is really important in terms of addressing what the patient needs and having adequate support, where you can look at the devices that might be used for hypercapnic failure with increasing support to the hypoxic failure and requiring cardiopulmonary support, such as in the pulmonary hypertensive patients. Our lung transplant program activity is shown here, and you can see we're steadily increasing the number of transplants we perform, doing 170 lung transplants last year. And our ECMO program is also growing. This slide isn't quite updated, but you can see that the activity is cardiac indication ECMO, ARDS, lung failure, bridge to recovery after transplant, and bridge to transplant is a growing activity in yellow. And in fact, in our program, it's about 10% of our patients every year that go to lung transplant on an ECLS device. But our practice has evolved over time, where we've really gone from having patients that were completely bedridden and anesthetized to sitting up, reading, and actually walking, ambulating on ECMO, which I think has improved our results. And here's a patient of Marcelo's too, where she was cannulated with a PCO2 of 122 on BiPAP that didn't even get intubated at all to be put on the device and bridged to transplant. We've also had patients like this, a gentleman who was transplanted 7 years ago, developed chronic lung allograft dysfunction, and we decided to list him for retransplant, and then he ended up getting respiratory failure. Now, he was a very committed patient and did his exercises in bed and sitting and so on, and we successfully bridged him to a retransplant. But I think that this is one of the things where, are you creating walking wounded, or are you really getting someone through? And that bridge to retransplant is a group that we still struggle with. But as you can see here, he was pretty good on his day of discharge from hospital, and a year afterwards, when his son was born, and he's still having a pretty active life. Now, we all have videos and pictures of people walking on ECMO and talking. How many times do we actually achieve that? And this is a very nice slide that Konrad Hotzenegger, who's Walter's colleague, made of our data when he was with us, showing that the fully ambulatory, you can see in yellow, we are increasing it over time, but we really don't achieve full ambulation all of the time, and it's about a third or 25% of the patients now that truly are ambulatory. And again, it does depend on how you cannulate them, and that's why we like to avoid groin cannulation when we can. And the same thing about extubation. How many times do we actually achieve extubation? I think we're getting better at it as time goes by. Again, it depends on the severity of illness of the patient and the intention. One of the things we're starting to rethink is extubation really the best thing, and particularly patients with septic lung disease. We have had some problems where the lungs then start to fill up with pus and de-recruit, and we get into more problems. And this is highlighted by a patient that you probably heard about. This was a 32-year-old woman with cystic fibrosis, was doing okay, but did develop H1N1 pneumonia, which tipped her over and ended up on BiPAP and then intubated at another hospital. And she was transferred to us because even though she was sort of on the edge of needing transplant, they felt she wasn't going to get through this intubation and episode. And we did a rapid workup for transplant on her, and she was listed as a ventilator bridge to transplant patient in our program, a pretty good candidate otherwise, other than rapidly deteriorating and being on a ventilator. When she got to our ICU, she continued to deteriorate, becoming acidotic with a PCO2 at 140, and we put her on VV ECMO and trached her the following day, but she continued to deteriorate, requiring high flow, and basically all of her bottles were positive on it with Pseudomonas and on her blood cultures, and she was requiring maximal vasopressors and inotropes despite high flow. And so this is the lady that we took to the operating room and performed bilateral pneumonectomies to get rid of the septic source. And what we did was to put a central VA ECMO for her cardiac support and a Novolung PA to LA for the pulmonary support, and she stayed that way for about 6 days before we did her bilateral lung transplant. Again, it was quite remarkable that we have the technology to do this, and literally when we took the lung out, within minutes she became completely stable, and we were able to turn all inotropes off, and it was what we had predicted based on surgical principles, and that was her about 5 months after that with her daughter. So I think that this might, again, it's a very extreme application of the technology, but it does show you what you can achieve. We looked at our experience in the last 10 years, 71 patients bridged to transplant. 89% of them were successfully got to lung transplantation. And in terms of looking at the results, you can see that these are patients bridged to transplant, and this is patients bridged to a retransplant. So the retransplant ones have been a significantly higher risk in our center. When you look at who we successfully bridged, again, patients that were successful were less likely to be ventilated and more likely to be the ambulated ones, as you'd expect. And again, more likely to have pulmonary hypertension or chronic lung allograft dysfunction, and less likely to have COPD as a diagnosis. If you look at the results, again, the 1-year and 5-year survival of the IPF-CF patients are slightly better than the primary pulmonary hypertension and chronic lung allograft dysfunction survival. And again, when you look at patients bridged to first-time lung transplant, the rest of our program and the bridge to transplant, and again, the rest of our program and bridge to re-lung transplant. So bridge to transplant and bridge to re-lung transplant is a significantly higher risk. So to close, I think successful bridging to transplant requires careful patient selection, avoid prolonged mechanical ventilation before putting them on pump, provide appropriate pump support for their needs, avoid groin cannulation if you can. Ambulatory and non-intubated, of course, is preferred, but again, avoid that caveat of lung de-recruitment, nutritional support and early trach, and certainly a resilient team that is engaged and multidisciplinary, with a multidisciplinary commitment to getting these patients. Bridge to first-time lung transplantation leads to very good short and long-term outcomes, in fact, almost equivalent to our regular patients, but bridge to retransplantation is more of a challenge, and successful bridging is associated with ambulation and weaning from ventilation, and these were two of our patients where we were able to achieve that and get them back to what's important to them in life. Thank you again for the